Hi, and thank you for joining us today for this talk on acute kidney injury for residents and acute nurse practitioners. My name is John Tsai. I'm from the Long Beach VA as well as the UCI School of Medicine. And today we'll be going over a couple of things on acute kidney injury. So let's first start off with a case. We have a 69-year-old gentleman, history of diabetes, hypertension, admitted through the emergency room for gangrene of the right foot. He's been having low-grade fevers over the last 3 days, no other COVID symptoms. His exam is here on the lower right-hand side where you see this gnarly right foot. He's a little bit febrile, 100.3, blood pressure is okay, heart rate's fine, setting 95% on room air. These are his initial labs. So he's got COVID that's negative, his white blood cell count is 10.3, and you go all the way down and you scroll down to the labs and you see a creatinine of 1.8. You say to yourself, wait a minute here, what is this creatinine of 1.8? And maybe he has an acute kidney injury. So I'd like to go over some goals that I'd like to cover here in this lecture. The first is what we mean by kidney function. What is GFR? What is creatinine? Then I'll be moving to how to differentiate between acute kidney injury and chronic kidney disease. Third, I'll be developing some framework for how to systematically classify causes of AKI so you can think about this in a more systematic way. Next, I'll go over our diagnostic workup for acute kidney injury. And then lastly, I'll touch base about what things that we look at in order to determine whether we need to consult us as nephrologists or not when we have a patient with acute kidney injury. Now, how do we necessarily assess somebody's kidney function? So the function aspect of the kidneys is really what we mean as the filtration aspect of the kidneys. And this is usually a volume per unit time. And this filtration is measured by the glomerular filtration rate. This is a clearance rate of a solute when the solute is neither absorbed or secreted. Here's the calculation here. You can see the formula there. However, it's actually really difficult to get an estimate or an actual glomerular filtration rate. And this involves injecting patients with substances, measuring it for 24 hours, and dividing it by the number of hours. So it can be very difficult. And so we want to try to see if we can use something that is inherent to our body that we can calculate an estimated glomerular filtration rate. And we usually use the creatinine as a surrogate marker. So remember that creatinine is produced by the muscles, it's excreted through our kidneys, and we can use this creatinine to estimate a GFR through some calculations. So here's the calculation that you can use. Obviously, these are not things to memorize, but you can find these on all the EMRs nowadays. So what they basically did was they took patients, put them in a lab, they measured their actual GFR, and they measured their serum creatinine, and they came up with these equations that estimate the glomerular filtration rate based upon the serum creatinine. And as you can see, there are some sex differences here between females and males. Okay. So the next thing I want to do is differentiate between acute kidney injury and chronic kidney disease. So there's this definition, the KDIGO definition of acute kidney injury, and it's split into 3 different stages. So stage 1 is the earliest acute kidney injury, all the way up to stage 3 when you have a severe acute kidney injury or on dialysis. Okay. Now you can see there's some cutoffs here with a serum creatinine, but there's also a urine output cutoff as well. So remember that when patients become all uric or anuric, that even without an increase in serum creatinine, that is by definition an acute kidney injury. Okay. So how do we assess acute kidney injury practically? Well, the first thing to do is absolutely you must determine a baseline creatinine, and that will help you determine whether the patient has a severe AKI or whether there's chronic kidney disease and maybe there's some fluctuations in the GFR. After that, then you can assess the trends. Okay, so I like to look at these 2 examples here as a marker of importance for determining baseline creatinine level. So the first case, we have a 35-year-old male with a baseline creatinine of 0.8. You see them in clinic with a creatinine of 1.4. Now, if you calculate the GFR drop from that 0.8 to 1.4, you can see that the GFR is dropped from 116 to 65. Now, for all intents and purposes, you would definitely classify this as an acute kidney injury. The patient has lost almost 50% of their kidney function, and that definitely is a severe case of AKI. Now, if we look at the second example here with a 67-year-old male with a baseline creatinine of 2.8, Now the creatinine is bumped to 3.4. This is again a 0.6 rise in the creatinine, similar to the previous one. However, if you calculate the GFR, you can see that the GFR change is only 22 to 18. So that 3-point difference is really not that significant compared to the 60-point difference that we saw in the case before. And I'd say, yes, maybe the patient has an AKI, but I'm not as worried about this patient, the second patient, as I am with the first patient. Okay, so here you can see it's very important to determine the baseline creatinine and assess that trend. And looking at the changes in GFR will help you determine whether this patient's AKI is actually significant or it's something that's not too significant. You can follow them up in clinic. So if we go back to our patient, that 69-year-old gentleman, history of diabetes and hypertension with the lab showing 1.8, if we go back to the chart and see, okay, the creatinine was 1.2 3 months ago. Now, if we calculate the GFR in that situation, the baseline creatinine was 1.2, GFR of 61, and the new creatinine is 1.8 with a GFR of 38. Based upon the 0.6 rise in the creatinine, we know that this is at least stage 1 AKI. Okay. Now, does this patient have an AKI? I would say yes. There is about a 20-point drop in the GFR, so that is quite significant, absolutely. Now, let's take a look at this other case where we have a baseline creatinine of 2.8. So now you see the patient in clinic with their creatinine of 3.2. Their GFR has dropped from 22 to 19. It is an increase in 0.3 milligrams per deciliter. So yes, it does meet criteria for stage 1 AKI. But is it greater than a 50% increase in creatinine? No. Okay, so in this case, is this an AKI? Probably not. The GFR drop is very minimal compared to the previous case. Does the patient have chronic kidney disease? Absolutely yes. And maybe the drop in GFR by 3 points is reflective of a progression of chronic kidney disease. And remember, there's also some day-to-day variation in renal function. So if you measure patients' renal function on a day-to-day basis, you will see that there is an increase by about 2 to 5 GFR points on a day-to-day basis. Okay, so this GFR drop or fluctuation from 22 to 19, and sometimes the next day it will be 21 or 23, that is not necessarily as significant as somebody with a persistent decline in their GFR. Okay, so now we've understood what is necessarily meant by kidney function, and we've differentiated between AKI and chronic kidney disease. Let's now develop a framework of how to systematically classify different causes of AKI. So this is the differential approach that I like to think about when I am assessing a patient with acute kidney injury. Okay, so if we think about the blood flow into the kidney, blood flow out of the kidney, and the actual kidney, we can determine or have a better differential diagnosis for our patient with acute kidney injury. So the first is pre-renal. So anything related to perfusion into the kidney can cause kidney injury. So things like volume depletion, heart, lung, liver disease, sepsis, increased abdominal pressure, renal artery stenosis, anything that leads to a decrease in perfusion to the kidney, we classify as a pre-renal cause of kidney injury. Okay. Now, if we look to the other side and the ureter side of the kidney, anything that causes obstruction to the urinary tract can also cause kidney injury. It's kind of like you block your sewage system in your house, and then you have an overflowing toilet over time if you keep flushing the toilet, right? So obviously you can't stop the kidney function from continuing to work, and so you will develop that waste in your body over some period of time. Okay? And so those are the post-renal etiologies of acute kidney injury. Now, the intrinsic renal encompasses quite a significant number of things, but more commonly we have acute tubular necrosis, or ATN. So this is the most common cause of AKI in the hospital, but there are some other causes of intrinsic renal etiologies as well that I'll get to over the next couple of slides. So let's talk about pre-renal. Now, pre-renal etiologies of acute kidney injury are the most common causes of AKI. And again, this is usually a result of a decrease in effective arterial blood volume that results in poor perfusion to the kidneys. Now remember, a lot of times we think about these as volume down states, trauma, sepsis, blood loss, things like that. But remember, volume up states or hypervolemic states can also cause a decrease in effective arterial blood volume. For example, heart failure patients. Now in heart failure patients, the patients are volume overloaded. There is strain on the heart that causes decreased pump of the heart that causes a decrease in effective arterial blood volume to the kidneys. So the kidneys think that they're not getting enough blood, and hence that there can be some acute kidney injury resulting from heart failure. Okay. Liver failure is kind of similar, where you have splenic vasodilation, you have blood flow into the abdomen, but unfortunately the kidneys don't necessarily see that blood. So in these cases, patients are volume up, not necessarily volume down, but that can also result in pre-renal causes of AKI. Okay. And if this AKI from pre-renal etiologies is sustained, you can eventually develop ischemic damage to the tubules, otherwise known as acute tubular necrosis. Okay. So how do we differentiate between patients that are pre-renal and maybe not pre-renal? Now, a lot of times we can do some calculations, otherwise known as a fractional excretion of sodium. So what this is essentially the percentage of sodium that is filtered by the kidneys and is excreted in the urine. Okay. Here is your formula here. And if you calculate the FeNA as being less than 1%, most of the time the patients are dry and you have pre-renal disease. Remember that sodium is avidly reabsorbed in response to volume depletion. Now, if you have a FeNA that's greater than 2, that means that the sodium is inappropriately being excreted, and usually there is some tubular damage there. And this helps us determine whether there's intrinsic renal disease or a pre-renal etiology to this patient's AKI. Now, of course, there are some issues with using this calculation, especially when patients are on diuretics. Now, when patients are on diuretics, the urine sodium is affected because the diuretics block the sodium reabsorption. In this situation, you could potentially substitute sodium for urea in the exact same equation that I showed you. But the cutoff is different. So instead of using 1%, we use 35% for our Phe urea, fractional excretion of urea, as being pre-renal etiology versus non-pre-renal etiology. Okay. Now, remember that kidney damage, existing kidney damage can also result in a FeNA being greater than 1%. Even though the patient has potentially pre-renal etiology. So when you're necessarily in doubt, let's say you are not clear whether the patient is pre-renal or has intrinsic renal pathology, it is very reasonable to give fluids. 500 cc's, 1 liter of fluids, unless the patient is grossly volume overloaded, that's probably going to be okay. Now, the question is, why can't I use FeNA in volume overloaded patients? And the reason is because in volume overloaded patients, the effective arterial blood volume is going to be low. And hence your FeNA without a diuretic is going to be low. But if you have a volume overloaded patient with a FeNA that's less than 1%, you're not necessarily going to give the patient fluids. So because of that, the FeNA in volume overloaded patients is not going to change your management. I would not get a FeNA in volume overloaded patients because it's going to confuse you. Okay. So if they're clearly volume overloaded, don't get a FeNA, diurese the patient, and treat them clinically rather than relying on the FeNA for those patients. Now let's talk about post-renal etiologies, and usually these are due to some sort of anatomical obstruction. It's a plumbing problem, okay? So stones, even unilateral stones, can result in acute kidney injury. Remember, each kidney takes 50% of the GFR. So if you block one kidney, you're essentially dropping that GFR by 50%. You can also have congenital abnormalities, especially seen in children or young adults, prostate issues, especially here at the VA where I work. We have a lot of old veterans who have prostate issues because our patients are 96% male. Malignancy and mass defect cause a lot of anatomical obstruction as well. And the treatment for these is to try to remove or reduce whatever obstruction is causing that injury. So if you have a stone, you want to try to remove it as quickly as possible, refer them to urology. Any prostate issues, you want to try to put a Foley catheter in them. If you can't cross the prostate, you may need to do a suprapubic catheter. And then of course, we send these patients to urology as well. Any anatomic abnormalities, especially congenital abnormalities, those are referred to urology. And then if you have patients that need percutaneous nephrostomy tubes, for example, you cannot cross whatever obstruction is resulting in their acute kidney injury, then you need to remove the urine somehow. And sometimes we need to do what's called a percutaneous nephrostomy, where we put a tube directly through the back into the kidneys to allow the urine to come out. And these are usually done by interventional radiology. So let's talk about intrinsic renal damage. So intrinsic renal damage can really occur at any part of the nephron. So there's generally four areas of the nephron, and these four areas of the nephron help to narrow down the differential diagnosis. So you've got the glomerulus, you've got the tubules, you've got the interstitial space, and then you've got the vessels, the blood vessels. So aside from acute tubular necrosis, other causes of intrinsic renal damage are actually fairly rare. So let's first talk about glomerular etiologies. Again, these are relatively rare. So if you have any of these, please give us a call. We'll be happy to help you out to help determine what you need to do next to work up these patients. So usually glomerular etiologies of AKI present with proteinuria and or microscopic hematuria. Of course, you want to rule out any urological issues, Foley trauma that can cause the hematuria. But if you have somebody who is presenting to you with proteinuria and hematuria with an acute kidney injury, give us a call and we'll be help you to differentiate urologic versus potential kidney issues. Now, glomerular etiologies can range from very benign causes of AKI to pretty severe causes of AKI that can lead to rapid deterioration of kidney function. And these are known as the rapidly progressive glomerular nephritides, RPGN. Most of the RPGN cases are what we call crescentic GN. And in these cases, we see a rise in the creatinine, usually over days to weeks. These can be intrinsic damage to the kidneys, or they can be part of some sort of systemic illness, for example, lupus or pulmonary renal manifestations can cause these types of kidney damage. Again, if you're seeing some sort of systemic illness, an acute kidney injury on top of that, and you have proteinuria and hematuria, give us a call and we'll be happy to help further management. These are complicated cases. We want to make sure that we treat them accordingly. So then let's move on to the tubules. Now, the tubular etiologies of AKI, especially acute tubular necrosis, are the most common causes of acute kidney injury that you'll see in the hospital. Okay? These are usually from renal ischemia, prolonged hypotension, surgery, sepsis. Basically, you have decreased perfusion to the kidneys. Now, a lot of times medications and IV contrast for CT scans can also result in acute tubular necrosis as well. So especially the iodinated agents that we use for CT scans, these can cause ATN. The nephrotoxins we talk about, vancomycin, aminoglycosides, cisplatin, tenofovir, synthetic cannabinoids, all of these are termed nephrotoxins and they usually result in nephrotoxicity through the mechanism of acute tubular necrosis. So the next are interstitial etiologies of acute kidney injury. And usually acute interstitial nephritis or chronic interstitial nephritis are basically allergic reactions to different types of medications. And these encompass about 70 to 75% of all cases of AIN and CIN that you'll see. These medications specifically are the most common offenders, NSAIDs, especially ibuprofen, Motrin, Aleve, aspirin in high doses can cause AIN or chronic interstitial nephritis. Some antibiotics, for example, vancomycin and ceftriaxone, rarely can cause AIN as well. And there are some case reports of proton pump inhibitors, PPIs, that can cause acute interstitial nephritis as well. In rare cases, infections, something called tubular interstitial nephritis and uveitis, if you have eye problems associated with this, can cause acute interstitial nephritis and chronic interstitial nephritis. There are also some systemic diseases, sarcoidosis, lupus, Sjogren's that can present with this as well. Now, a lot of times we think about the triad, so the triad of rash, fever, and eosinophilia, along with acute kidney injury, as being almost characteristic of acute or chronic interstitial nephritis. Unfortunately, very, very few patients actually have all three, and it will really be based upon clinical suspicion of some sort of acute or chronic interstitial nephritis that will lead us to potentially getting a biopsy, removing possible offending agents, and potentially giving steroids if we think that the case is severe enough. Lastly, we've got vascular issues. So these can range from large vessel issues to small or medium vessel issues here. So in the large vessel issues, these encompass fibromuscular dysplasia, atherosclerosis, and vasculitis. Atherosclerosis being very common, especially in our older patient population. Vasculitis is common, especially in our younger, and fibromuscular disease also in our younger patient population as well. Now, the small and medium blood vessel issues can usually happen towards the later ages, especially ankylosing, which we see more commonly in the older patient population, cholesterol emboli, especially after some procedures, hypertensive changes and diabetic changes can result in these small arteriolar changes as well, resulting in more chronic kidney disease instead of acute kidney disease. So now we've developed a framework for how to systematically classify causes of AKI. Let's work on understanding what we do in order to perform the diagnostic workup for anybody with AKI. So this is essentially a shotgun approach, and basically depending upon your clinical intuition, you can narrow this as you see fit. So if you think that patients have a pre-renal etiology, again, you can get a FeNA or Phe-urea if the patient's on diuretics. The urinalysis is helpful in some situations, especially the specific gravity. Specific gravity can sometimes be a marker of hydration status. So if you have somebody with a specific gravity that's higher than 1.020 or 1020, then these patients may be dry, for example. And again, a fluid challenge is actually a diagnostic test. You give the patients fluids. If they get better, then you're more suggestive that this was a pre-renal etiology to their acute kidney injury. For post-renal etiologies, usually we ask you guys to get ultrasounds or post-void residuals, but in certain situations, for example, you think maybe there's stones or some anatomical process, you can get a CT scan as well. And then for intrinsic renal etiologies, we check the UA, especially looking for, again, hematuria and proteinuria for some glomerular etiologies. And you can also get a microalbuminuria panel, which is essentially looking at the albumin to creatinine ratio. How much protein is the patient producing to see if they have some glomerular etiologies. We can look at the urine sediment exam as well, which I'll be showing you on the next slide. And the other labs help us determine some sort of pattern of injury that helps us to distinguish between the 4 different areas that can cause intrinsic renal damage. So this is what urine sediment looks like. So this is after we collect the urine. So usually, hopefully, we can get the urine within 15 minutes down to the lab, spin it down, and then look at it under the microscope. And these are some things we can see. So in the upper left-hand corner, we see a hyaline cast. So hyaline casts are indicative of some sort of pre-renal etiology, that the patient may have been dry in that situation. And hopefully, if you give them fluids, they'll get better. On the upper right-hand side, we have a muddy brown cast. So this is indicative that the patient has acute tubular necrosis. On the lower left, we have some RBC cast, which is indicative that the patient may have some sort of glomerular nephritis or glomerular etiology to their acute kidney injury. And then lastly, we have on the lower right-hand side the white blood cell cast, which is very classic for acute interstitial nephritis. Now, these are relatively rare to see, but if you see them, they are more diagnostic of these etiologies. So what does this look like for a patient? So if we go back to our case study, 69-year-old gentleman with a history of diabetes, hypertension. If we recall that the creatinine was 1.2 at baseline, now it's 1.8 on hospital day 0. The urinalysis was negative. The emergency room gives them 2 liters of fluids. The patient has started on antibiotics for suspicious for cellulitis and maybe osteomyelitis. And on hospital day 1, the creatinine is down to 1.4. Now, if we calculate the GFR, that's 51. And we say we're happy, right? The creatinine has gone down, the kidney function has improved, and this is supportive of a pre-renal etiology of this patient's AKI. Now, let's say after we give fluids and antibiotics, on hospital day 1, the vascular surgeons say, hey, we need to get a CT scan with contrast to look at this foot a little bit better. And unfortunately, the hospitalist also starts the patient on gentamicin for gram-negative rods growing out of the wound. Okay. The patient is looking better. He's now afebrile. But now in hospital day 3, we have a patient that has gone up in his creatinine again. So it went from 1.4 to 1.8. The GFR has dropped back down to 38. And now we have urine showing 1+ red blood cells, 1+ protein. A renal ultrasound is ordered. The PVR is 0. And then nephrology is called to spin the urine. Okay. Now, this is a really good segue in terms of when to call us for consults for acute kidney injury. So what can we do to help you guys out? So again, call us anytime. We'll be happy to help you out with any renal issues. But in general, we can assist with diagnostic workup for acute kidney injury, performing urine sediment exam, as in this case, guidance on really complex cases. If you get any weird or interesting cases, those are good learning topics for us, and we'd love to get involved with those cases. AKI is not improving, obviously call us. And then of course, if you think they're going to need dialysis, nothing is getting better, patient's getting more and more volume overloaded, or they have electrolyte abnormalities, give us a call and we'll be happy to help you out. So if we go back to this patient's urine sediment exam, we spin it and we see this. So this is full of muddy brown cast, which would be consistent with acute tubular necrosis. So we can say that the urine sediment exam with the muddy brown cast is consistent with acute tubular necrosis. Now again, acute tubular necrosis has a lot of different etiologies, right? So where did this patient get their acute tubular necrosis from? And then there's obviously several things here. So the patient got a CT scan with contrast. And recall that the contrast usually results in AKI about 48 to 72 hours after the exposure. It does not happen right away. Okay. Similarly, with aminoglycosides, you will see the creatinine bump 48 to 72 hours after the exposure. Sepsis, the patient was septic when they came in, blood pressure was a little bit low, white count was a little bit high, maybe the patient had prolonged hypotension, and a lot of times it is all of the above, that we can't necessarily find out one single reason why the patient went into acute tubular necrosis, but it is multifactorial, where the patients have several different etiologies of kidney injury, and we kind of say, well, it is multifactorial, and then we're going to work on avoiding that in the future to making sure the patient doesn't get further contrast, for example, or aminoglycosides to make sure that the kidney function can recover over time. So let's follow this patient out. On day 4, the gentamicin is discontinued, the creatinine is 3.0, he's still afebrile, he's actually looking better. They changed the patients to vancomycin and cefepime. On day 5, the creatinine is still going up, but you wait until day 6, creatinine is 4.2, creatinine on day 7 is 5.0. Now, this happens a lot, unfortunately, and we like to think that even after stopping all the nephrotoxic agents, the creatinine will start to downtrend immediately. But unfortunately, that is not the reality. A lot of times, the creatinine will continue to rise despite everything that we're doing, just because the patient takes time for the kidney function to recover, especially in really severe cases of ATN. So ATN, basically, not a lot of specific treatments except to prevent patients from having further injury to their kidney, making sure that they're not hypotensive, making sure they're not on nephrotoxins, making sure they're not taking any NSAIDs. And sometimes we just need to wait it out until the patients get better. Okay. So I have seen patients who go on for many, many months on dialysis before they recover, and it can be 3 to 4 to 5 months before they actually recover kidney function and are able to come off dialysis. So AKI in the hospital is actually very common. So actually up to about 20% of hospitalized patients do have AKI, of which of those, 10% of those will require dialysis. So that is a relatively small proportion of hospitalized patients that have AKI. But again, these patients can be severe. They can take up a lot of resources. AKI also occurs in the setting of acute and chronic illness. Okay. There are risk factors such as older age and presence of CKD that can predispose you to getting acute kidney injury. Now, what do we do in these situations? Monitor them, continue measuring the creatinine, continue monitoring their kidney function, their GFR and urine output throughout their hospitalization to look for signs of kidney recovery. Okay. And then, of course, you want to reduce the risk of further AKI, prevent and treat volume depletion, and avoid other nephrotoxic drugs, as I mentioned earlier. Now, if all else fails and the kidney function continues to decline, then we have renal replacement therapy. So renal replacement therapy in the form of dialysis does not make the kidney function better. It replaces the kidney function while the body is able to recover on its own. Here in the United States, about 90% of people end up on hemodialysis, with 10% of people on peritoneal dialysis. And most patients with acute kidney injury, they will be started on hemodialysis. Now, what are the indications for acute dialysis? Now, if we think about the AEIOU, so that's acidosis, severe acidosis that's refractory to medical management, electrolytes, specifically potassium and hyperkalemia, but also hypercalcemia can be dialyzable as well. That is refractory to medical management. any sort of ingestions that can be dialyzable, volume overload, especially patients that have respiratory compromise or refractory to diuretics, and then uremia, severe symptoms of renal failure such as a pericardial rub. These patients require dialysis. Okay. When in doubt, when you have a question about whether the patient needs dialysis or not, call us and we'll be able to help triage those patients. And when you have patients with AKI, it's helpful to obtain kind of a full set of labs. So at least get a Chem 7, which is your sodium, potassium chloride, bicarb, BUN, creatinine, and glucose. But if you can get a Chem 10, it can help us to help you out with some other complications of acute kidney injury and chronic kidney disease as well. And we use all this information to basically make an informed decision regarding initiation of hemodialysis in these patients. So if we go back to our patient on hospital day 5, we have a creatinine of 5.0, potassium has gone up to 5.2, bicarb is 19, BUN of 70, calcium is 8.3, phosphorus is high at 6.2. And you're like, does this patient need dialysis or not? And the first thing to think is, okay, are there any of these electrolyte abnormalities that will kill the patient first? And those are the things that you need to treat immediately. So treat potentially fatal electrolyte abnormalities first. And these are potassium abnormalities, especially hyperkalemia, metabolic acidosis, especially if it's severe, calcium, critically low or critically high calcium levels need to be treated, and then hyponatremia. Now, phosphorus, while it's high in this case, is not an immediately fatal electrolyte disturbance. So don't worry about the phosphorus. Usually as the patient's kidney function improves, the phosphorus level will get better as well. Now, how high can the BUN go before we need to necessarily start dialysis? And there's no really one number that the BUN level is before we think, okay, this patient definitely needs to start dialysis. A lot of times these patients will have BUN levels over 100, but I have seen patients with BUN levels that are under 100 that have other reasons to start dialysis. So it's really a full picture, including the patient, what they're doing, how they're being treated, and how dialysis can necessarily help that patient in the short and long term. So let's go back to our patient. The creatinine was 5. It's got hyperkalemia, acidosis. You treat those with medical management. The urine output starts to pick up at 1 liter per day. On day 8, day 9, day 10, you can see the creatinine coming down and the urine output start to pick up. Okay. Now it's important to monitor the urine output because this is really the first sign of renal recovery. Okay. As you can see here, even though the kidney function was, the creatinine was getting worse, the urine output was getting better. And that gives us some hope that the creatinine will start to improve over time. So monitor the urine output. That is usually the first sign of kidney recovery. And usually after the urine output starts to pick up, the creatinine level will start to downtrend. So let's continue this case. This becomes a very interesting case. Creatinine has downtrended to 4.4 on day 11. Day 14, again, it's 4.4. On day 15, suddenly you have a creatinine of 4.8. And now you're like, well, I've done everything I can. He's not on any nephrotoxins. He's doing better now. Why is the creatinine going up? So we repeat the UA. It has 500 protein, has moderate blood, 17 RBCs. Repeat ultrasound, wait, but he got one already. There was no hydronephrosis. Everything was good on hospital day 3. And the labs are here, where the electrolytes are fine. So how do we necessarily approach this case? Okay, now that we have an in-hospital acute kidney injury in this case. So again, we systematically go through the framework that I talked about. We go through pre-renal etiologies, post-renal, and then intrinsic renal. So here in this case, pre-renal etiologies, especially for a patient that has been in the hospital for several days, it's usually unlikely, unless you're diuresing the patient aggressively, it's unlikely that patients develop a pre-renal etiology in the hospital, right? Now in post-renal, we got an ultrasound a long time ago. It didn't show any obstruction. It's unusual that suddenly the patients will develop an obstruction in the hospital over the last 12 to 13 days. And now we're thinking, okay, maybe this is an intrinsic renal cause, especially given that there's proteinuria and hematuria. Could it be suggestive of something that's intrinsic? Now again, we go through our 4 areas in the kidney to narrow our differential diagnosis. Our vascular system, right? Our tubular system, interstitial, and glomerular. And in this case, it's unlikely that the patient has any vascular issues. Tubular issues would be unusual. Again, the patients can have ATN, persistent ATN, but it's unusual to get ATN again, especially if you've been monitoring the patient very closely over the last several days. Interstitial, the patient typically doesn't have hematuria if it's an interstitial case, so there's no white blood cells in this case. And then we're thinking maybe this is some sort of glomerular etiology. So if you get something like this, give us a call and we'll be happy to kind of help lead the differential diagnosis and do further workup on these cases. So especially for proteinuria and hematuria, we're thinking some sort of acute glomerulonephritis in this case. So this is our differential diagnosis for acute GNs. Could there be some sort of rapidly progressive RPGN, rapidly progressive GN, ankylosing, anti-GBM disease, or Goodpasture syndrome, or some sort of IgA nephropathy? Does this patient have lupus, or does this patient may have post-infectious GN, formerly known as post-strep GN? And then there's some non-acute GNs, which would be less likely given the acute nature of this case. MPGN, FSGS, or IgA are kind of non-acute GN cases that are less likely on the differential diagnosis here. So if all else fails, we can get a renal biopsy in these cases. And in this case, we got a renal biopsy and the patient showed post-infectious GN. So what is the treatment for post-infectious GN now? Not too much, unfortunately. So we would continue the antibiotics, and usually the post-infectious GN gets better over time. You just kind of have to wait it out, kind of like ATN, where you just wait, do supportive therapies for these patients until they get better on their own and the infection clears. So the good news is 2 weeks later, the creatinine improves to 2.2, the patient is finally discharged on hospital day 25, and then we see this patient in renal clinic post-discharge with a creatinine of 1.6, and the patient is doing well. So let's recap on this lecture today and all the goals that we went through. So we talked about understanding what we mean by kidney function, the difference between estimated glomerular filtration rate and creatinine. How did we differentiate between acute kidney injury and chronic kidney disease by looking at baseline creatinines, looking at trends, as well as looking at the urine output. We then moved to develop a framework of how to systematically classify acute kidney injury, especially looking at pre-renal causes, post-renal causes, and intrinsic renal causes. And then we went to understanding what is the diagnostic workup involved with acute kidney injury. Now, specifically urinalysis, labs, and ultrasound, especially to detect any post-renal etiologies. And then finally, we talked about when to call nephrology for a consult. Okay. Again, we're here for you guys. We're here to help you out, especially when in doubt. But patients with AKI that especially doesn't resolve within 24 to 48 hours, or you think the patient needs dialysis, or you're really unsure of what to do next, we are here to help you out, okay? So that's all I have for you guys, but if you want to read up more on acute kidney injury, this is a great resource. It was published by the Annals of Internal Medicine in the clinic acute kidney injury. This was published in 2017, so an oldie but a goodie. It covers a lot of the information that I talked about during this lecture, and a good reference to have in case you have any additional questions. So thank you very much for your time, and we'll see you next time. Take care. Bye for now.